Thank you. So I decided to do an endeavor on looking at the next generation biomarkers in prostate cancer. And when I first did a literature search in this area, it was overwhelming. There's just such a number of papers in the field. There are 8,000 papers in 2011. And I found it actually quite difficult to navigate the literature today. So hopefully I'll be able to give you a good summary as to what the next generation biomarkers are right now and where I think they might be going, or at least what direction others might think they're going. So the objectives of my talk are to highlight why biomarkers are important in prostate cancer management, identify key clinical scenarios where biomarkers offer the most relevance, highlight some of the new tissue, blood, urine, and image-based biomarkers that are coming out the pipeline, and describe what others and myself think the future of next-generation biomarkers is to date. As you know, PSA has had a significant role in prostate cancer management. It's got an established role in the progression of disease and as well as the response to treatment and relapse of the disease. We have here a controversy in the screening of with PSA for prostate cancer. And you can see these two plots. The European study, randomized study of screening for prostate cancer that included about 160,000 people. It demonstrated after 13 years of follow-up that there was a survival benefit in those that were screened for PSA. Whereas the prostate, lung, colorectal, and ovarian cancer screening trial did not demonstrate a similar effect. And this was approximately 77,000 patients included in this trial where they did not see a significant difference in survival by screening with PSA. So as you know, the Canadian Task Force has come out with strong guidelines that for men of all ages, they do not recommend PSA screening. And in a rebuttal to that, the CUA have actually come out with sort of guidelines as to why this may not be the best recommendation for patients. They show that none of the screening trials were powered to demonstrate a decrease in overall mortality. Current reviews underestimate the benefit of screening, which states as 1.28 deaths avoided per 1,000 men screened. Evidence for decreased metastatic disease is important, and it was not included in these studies. That active surveillance has been widely adopted in Canada and has not been mentioned in these guidelines. And also the GU Cancer Tumour Group locally, the BC Cancer Agency and the Vancouver Prostate Centre have come out with some of their own guidelines. Asymptomatic men 50 years or older with an estimated life expectancy of more than 10 years who are well informed about the risks of overdiagnosis and overtreatment can consider PSA testing for the early diagnosis of prostate cancer. And I really agree with them. Now, to define biomarkers, there are sort of two types that I'd like to talk about today. Prognostic biomarkers, which provide information on the likely course of the disease in an untreated individual. So you can see in the diagram that there are several patients that may have a diagnosis of prostate cancer with a biopsy, and we can better identify those that will do well, such as the little blue man there. He may not do as well from the disease, and that's what a prognostic biomarker would do. Whereas a predictive biomarker can be used to identify subpopulations of patients who are most likely to respond to a given therapy. So of those 4 patients that go on to treatment, with whichever treatment it might be, the patient, the blue man there, is the one that will respond better to that treatment and predicting that. So keep these in mind when we talk about some of the biomarkers that I'll share with you. I also think it's important to highlight where these biomarkers are needed in prostate cancer. In particular, how do we distinguish aggressive disease from indolent disease in patients on active surveillance? About 25 to 40% of patients who are deemed eligible for active surveillance have biopsy pathology that underestimates their tumor extent or grade, and thus, by this mark, we're resulting in delay of treatment and potentially decreased chance for cure. Multiple repeat biopsies in active surveillance causes a lot of morbidity. In fact, about 7% of low-risk patients develop sepsis from these biopsies or infection, and 1/3 of patients have to take medication for pain after getting a biopsy. The next group is how do we identify patients with localized prostate cancer who will benefit from radiation therapy post-radical prostatectomy. In patients with high-risk lymph node negative disease that especially have adverse pathological features such as positive margins, seminal vesicle invasions, perhaps adjuvant radiation therapy will reduce the risk of biochemical recurrence. And in the SWOG trial, this was shown, although this trial has been criticized because it underutilized early salvage radiation. Thompson actually demonstrated that the number needed to treat with radiation to prevent one case of metastatic disease at 12 years follow-up was 12.2. This is considered relatively unfavorable because radiation has several side effects, late and early toxicities, such as urinary incontinence, sexual dysfunction, GI side effects, and secondary cancers. So the question really becomes, can we identify those patients that would benefit so we don't put them all through these side effects? And lastly, the other cohorts the other group we'd like to look at is how do we select and sequence drugs for patients with castration-resistant prostate cancer in the context of several recently approved agents in this field or recently developing agents. As you know, this area is rapidly growing and there's several drugs available, abiraterone, enzalutamide, cabazitaxel, radium, etc., and there's more coming down the pipeline. How do we actually treat these patients and what's best for them in a personalized approach? So keeping these clinical questions in mind, I'll talk about some of the tissue markers that have recently been developed. I'll talk about the Myriad genetic Prolaris score, the Genome Health Oncotype genomic prostate score, the Genome DX Biosciences Decipher, and the NF-kappa B predictor. The Myriad genetic Prolaris score is a 31 to 46 gene RNA expression signature from which they discovered in formalin-fixed paraffin-embedded biopsy specimens. And the data today shows that this score has been a predictor for biochemical relapse after radical prostatectomy, as well as after external beam radiation in approximately 700 patients. They've also shown that in another paper that it's a predictor for overall survival, especially when combined with the Kappa-S score. And this is a pre-treatment assessment tool that includes PSA, Gleason score, clinical stage, percent positive biopsies, and age. When we look at this Kaplan-Meier, you can see that those patients with a worse CCP score or Prolaris score in the darker color there have a significantly worse progression-free survival than those with a more favorable score. So it's been used to predict those that will do poorly after radical prostatectomy. Looking at the Genome Health Oncotype DX genome prostate score, it's a mouthful. It's a 17-gene RNA expression signature, again from biopsy specimens that are paraffin embedded. And the data suggests that it's a predictor of suitability for active surveillance, and that in the same population, if you again add it to high-risk Kappa-S score patients, then those patients with both high GPS and high Kappa-S scores have markedly elevated post-radical prostatectomy risk for lethal prostate cancer. So this one actually may have some relevance in active surveillance as well as progression of the disease. When we look here, you can see that those in the red here with both high Kappa-S and GPS scores have significantly worse prostate cancer specific mortality as compared to those with more favorable scores. So this might be useful in deciphering those patients after radical prostatectomy that have a higher chance for disease spread and biochemical relapse. Now, there's a lot of focus that's been on the Decipher score. There's a lot more data that's been out there, and it's a 22-gene RNA expression signature. Again, these are in radical prostatectomy specimens, and early data showed that it's a predictor of early metastasis in high-risk patients. And when we look at some of the data, you can see those with a high Decipher score in the pink here at 5 years have a 1 in 4 chance of developing metastasis, whereas those with a low risk or in the blue here, you can see that those patients have a 1 in 42 chance of metastasis at 5 years. So this is quite good data to suggest that the genome DX Biocipher or Biosciences Decipher score may be very good at predicting those that will go on to develop metastasis. Further data has shown that it's a predictor for biochemical relapse and metastasis in high-risk patients post-adjuvant radiation. It's a predictor for early metastasis in high-risk patients when combined again with the Capra-S score. And it's a predictor for early metastasis again after radical prostatectomy. Now, this is the only tissue-based signature that's been shown to possibly change the practices of urologists. And this is a study where they looked at the impact of knowing the score of these patients on what urologists recommended to their patients. And you can see on the y-axis you have the frequency, and then the two groups, the low risk and the high risk scores. And what this study showed is that the high risks, those urologists that were not given the Decipher results, they suggested observation in 51% of their patients, whereas if they were given the Decipher high risk results, then they recommended 35% observation. So there was a significant change in their practice of what they recommended to their patients based on this score, and it might have good clinical utility. Looking at the NF-kappa B activated recurrence predictor 21, it's a 21 gene signature in radical prostatectomy specimens. It's been shown to be a predictor of metastasis-free and disease-specific survival. And you can see in this Kaplan-Meier survival analysis, those with predictive NF-kappa B signature that was low were at worse probability of metastatic-free survival. So again, this might be an important tool in predicting metastasis. There's several of these tools out there. They have different cohorts or patient groups which they can be applied to. It's actually quite difficult to decipher which one might be better, and they haven't done head-to-head control studies on these. But nonetheless, the Prolaris score and the Oncotype DX score can be used on prostate biopsy tissues to identify adverse pathological features that might predict those patients who may benefit from coming off active surveillance and getting radical prostatectomy or radiation for that matter. The Decipher, Prolaris score, and the NF-kappa B signatures have been designed to predict clinical outcome after radical prostatectomy. And I think with the data out there, I think that a lot of it points to the Decipher being ahead of the game. It's been validated in multiple cohorts and demonstrated a potential to influence clinical decision-making after radical prostatectomy. And more recently, it's been covered by Medicare in the last week. Now, looking at tissue-based gene signatures as a whole, a critical consideration for these is that the tissue markers were undersampling the prostate, and there's a risk of missing a threatening tumor by taking these tissue samples. All of these studies have been done retrospectively, and I think optimal clinical validation to prove clinical utility will require prospective clinical trials. And also they're expensive. In fact, the Prolaris score costs the individual patient $3,400, the Oncotype DX score is $3,800, and the Genome DX, they're all comparable, $4,250, and the NF-kappa B does not have a cost associated at this point. But the Genome DX has been covered by Medicare as a post-operative predictor. The question is Medicare going to cover these in the future? I think that they'll demand more prospective studies as data to move forward. Now, moving on to some of the blood-based biomarkers, this seems more interesting because you can get a full look at a tumor specimen by taking the blood sample. We'll touch on microRNAs, cell-free DNA, and circulated tumor cells. MicroRNA are small non-coding RNAs found in tissue and serum samples that are involved in post-transcriptional regulation of a large number of biological processes. So you can take the microarray from a sample, and its function is to induce gene silencing by binding to target sites in the 3-UTR region of mRNA. And it's involved in a wide range of biological processes such as cell cycle control, apoptosis, and several other pathways. And it's been looked at as a biomarker. If we look at the progression of the disease, microRNAs have found a good niche throughout the diagnosis as well as active surveillance, localized disease, and castration-resistant disease spectrums. In diagnosis, the microRNA 141 has been associated with higher Gleason score. The microarray 16 has been demonstrated to help discriminate prostate cancer from BPH at biopsy. And higher levels of microRNAs are correlated with a prostate cancer diagnosis as compared to BPH. No data that I was able to find in active surveillance. In localized prostate cancer, a signature of 3 different microRNAs was predictive for biochemical failure at the time of radical prostatectomy. The microRNA 182 expression has been associated with biochemical and clinical free survival. And in castration-resistant disease, the microRNA 375 and 141 have been associated with high-risk prostate cancer and metastatic disease potential. Furthermore, higher levels of microRNA have been associated with worse outcome on docetaxel chemotherapy in these patients. So this particular microRNAs may play a role along the whole spectrum of prostate cancer except active surveillance. Now looking at cell-free DNA, these are small amounts. There's small amounts of cell-free DNA in plasma, which likely originates from cancer cells and therefore may constitute a source of genetic material for identification of tumor-associated molecular alterations. So we can harness this. Dying tumor cells release small pieces of their DNA into the bloodstream, and these are known as cell-free DNA, and we can pick these up with biological assays and screen them as potential biomarkers. Screening cell-free DNA for somatic mutations can also help detect and follow the progression of a patient's tumor. Looking at disease progression again, the cell-free DNA have been helpful in deciphering prostate cancer again from BPH, have been associated with tumor stage and category. In localized disease, they've been significantly shorter biochemical recurrence-free survival has been associated with higher values of the cell-free DNA. And in castration-resistant disease, the presence of the androgen receptor gene aberration in cell-free DNA is correlated with radiographic and clinical progression on enzalutamide, an AR target agent. And the detection of AR gains and mutations in the cell-free DNA is associated with resistance to abiraterone as well as the novel drug ARN-509. Circulating tumor cells have had a lot of clout in the literature recently, and so I think we'll spend a little time on this. Rare circulating tumor cells in the peripheral blood, they may have an important role in tumor dissemination and progression. In one given sample, there's actually about 1 CTC cell in approximately 1 millimeter of blood. You get pooled CTCs in a sample, and then you can actually utilize capture technologies to split these into those that are metastatic and those that are primary. And what we can do with this is actually look at the mechanisms of disease progression by looking at the characteristics of these CTC cells. Now, circulating tumor cells do not play a significant role in the diagnosis, active surveillance, or localized prostate cancer. I did find one paper that looked at CD17 CTC levels that they were found to decrease after radical prostatectomy and increase again once biochemical recurrence was occurring. Now, they play a significant role in castration-resistant prostate cancer, and there's a lot of data to suggest that unfavorable or higher levels of CTC counts are predictive of shorter overall survival in progressive patients, as well as in other castration-resistant cohorts, that they're a predictor of overall survival in patients treated with docetaxel, and they're associated with high risk of death, bone metastasis, and more recently, this study at the bottom, the CTC with the ARV7 positivity associated with lower PSA response rates, shorter PSA progression-free survival, and shorter overall survival in patients on enzalutamide or abiraterone. It's hard to decipher which of these two because some of the patients had previously been treated with abiraterone or enzalutamide in the study, so there's some overlap. Some of the limitations to CTCs that limit its clinical utility is not having sufficient DNA capture due to low number of CTCs in biological samples. There's a lot of platforms that are being utilized to isolate these CTCs. They utilize antibodies, transcripts, functional tests, natural selection, and physical properties to isolate these CTCs. And there's currently new technologies trying to overcome this shortcoming of having sufficient DNA due to the low number of CTCs, such as microfluid ratchets, which is an ultrafiltration method. Nonetheless, blood-based biomarkers may play a significant role. MicroRNA can be used to predict outcome of patients on docetaxel chemotherapy. Cell-free DNA can be used to predict resistance to enzalutamide, abiraterone, and ARN-509. CTCs can be used to prognosticate disease and predict response to enzalutamide and abiraterone. Blood-based biomarkers are very novel to us in that, and very exciting, because they have the potential to overcome the inherent heterogeneity of the prostate cancer and capture the tumor characteristics in their entirety. I think it fulfills the goal of this liquid biopsy that we're looking for, and that we're able to monitor molecular changes in response to therapy with blood-based biomarkers. Thus, we're able to monitor drug targets and guide corresponding alterations in therapy, the essence of precision oncology. Now, urine would be an even better medium, because then you don't have to poke the patient. So looking at some of the urine-based biomarkers, I don't think the data is as strong as the tissue-based biomarkers, but I think it's important that we do address them. There's the PCA3, the TMPRSS2 ERG, and the metabolome Prolaris. And I must mention there's several other blood-based biomarkers and urine-based biomarkers that are in the literature, and this is just a summary of some of the ones I think that might have a role in, at this point. PCA3 is a prostate-specific gene located on chromosome 9q that can be detected in urine samples. The urine PCA3 assay has demonstrated a sensitivity of 69%, specificity of 79%, and predicting prostate cancer diagnosis in men undergoing biopsy. And you can see here that those with higher PCA3 score have associated higher positive biopsies. And so this PCA3 assay is predictive of those patients who need repeat biopsy when they have elevated PSA and a previous negative biopsy. And it also may be predictive of be associated with increased probability of finding cancer on initial biopsy. Higher PCA3 levels have been also associated with higher volume prostate cancer and high-grade disease on active surveillance. So it might play a role in the diagnosis and the active surveillance cohort or populations. The TMPRSS2 ERG gene is a gene fusion involving the 5' untranslated region of the androgen-regulated gene TMPRSS2 with ERG or ETV1 that can be detected in urine samples. Detection has yielded a specificity of 93% and a positive predictive value of 94% for the diagnosis of prostate cancer in patients that have high PSA or an abnormal DRE. So it might also have a role in the diagnosis of prostate cancer. Looking at some of the clinical evidence, the TMPRSS2 detection is an independent predictor of Gleason score and tumor stage, and it's been associated again with higher volume prostate cancer and high-grade disease in active surveillance. And more recently, the metabolome Prolaris score is a 4-metabolite signature detected in urine by LCMS, where if we looked at the disease progression again, the biopsy Prolaris score has been associated with increased risk of prostate cancer. In localized disease, it's a predictor for disease-free survival. And in castration-resistant disease, where they've actually looked at the metabolome signature in urine samples as compared to other mediums, it's associated with metastasis. So this might offer a novel urine tool to look at the different aspects of disease progression. So the PCA3 assay can be used to predict need for repeat biopsy in men who have elevated PSA and a prior negative biopsy. The Prolaris score has been used to stratify the risk of patients with previous negative biopsy for occult cancer, and it's also been used to predict disease-free survival and metastasis. Urine-based biomarkers, we can collect them in large quantity. It does not involve poking the patient, so they seem quite appealing to us. And so I think that they have a lot of, we should spend a lot of our emphasis on developing these and screening in early stage disease. And I'm going to touch a little bit on some of the image-based biomarkers. I think that there's a lot of development in this field, but I don't think it's where it should be at this point for clinical utility. Looking at MRI, it's important in diagnosis because it helps determine the best location for repeat biopsy in patients. In active surveillance, it can help in determining the stage of the disease. In localized disease, it can help determine extraprostatic extension prior to radical prostatectomy. And in castration-resistant disease, it's predictive of biochemical relapse after radical prostatectomy. Just an example here, you can see in figure A, this is a MRI of a patient, a 76-year-old man who's had 4 previous negative biopsies and a PSA of 329. And A, you see a high-resolution T2 weighted image. On the right side, you see an oval, solid, hypointense lesion. And in B, you see the subtracted perfusion scan showing a hypointense zone in the same area. And in C, you can see that this area is representative of possible intermediate grade aggressiveness using this technique. And D shows the choline peaks associated with this, and the choline peaks are typical of cancer's metabolism. So it's more indicative of a cancer on MRI with these results. And at time of radical prostatectomy, the pathological correlation for this patient was Gleason score 8, 4+4 disease. So what this sort of is an example of is that MRI might be used to better determine the diagnosis of prostate cancer. Now, PET, I don't think there's PET CT. There's not as much data out there on the importance of this as a biomarker. In fact, there were a couple of studies that just showed that PET might be used in early phase biochemical relapse to identify disease at that time. So based on this, MRI may have clinical utility at diagnosis, active surveillance, localized prostate cancer, and castration-resistant prostate cancer settings with the use of other biomarkers. And PET may have some utility in the castration-resistant prostate cancer setting, but I think there's a lot of work that needs to be done in this area. And this is something that Dr. Black's working on. This is utilizing the MRI for quantitative image analysis, and it's really a novel concept to help sort of look at prostate cancer. This is an example in breast cancer where they looked at the features of triple-negative cancers versus a fibroadenoma, and they can take the raw data from this and actually decipher the differences out on this plot. And what's important about this is that using the raw data, they can do machine learning that can be applied to pattern recognition algorithms that can be developed to predict disease present, stage, and grade based strictly on imaging criteria. And so I think moving forward, quantitative image analysis can be used to measure tumor response to therapy, which can also in turn guide clinical decision making. So going back to the key clinical scenarios for prostate cancer or biomarkers in prostate cancer. So how do we distinguish aggressive disease from indolent disease in patients on active surveillance? How do we identify patients with localized prostate cancer who will benefit from radiation therapy post-radical prostatectomy? And again, how do we select and sequence drugs for these patients with castration-resistant prostate cancer in a personalized approach to benefit them? At diagnosis, blood-based microRNA and cell-free DNA can be used to discriminate prostate cancer from BPH. Urine PCA3 can prognosticate need for biopsy in men who have elevated PSA negative biopsy. And the Prolaris score can help stratify occult cancer in men with previous negative biopsy. In active surveillance, some of these tissue-based signatures, Prolaris and Oncotype DX, can identify patients on active surveillance that may benefit from coming off and having active treatment. And MRI may help focus repeat biopsies on specific prostate lesions. In localized prostate cancer, tissue-based gene signatures can predict, like the Decipher can predict recurrence and progression after radical prostatectomy. Blood-based microRNAs can predict biochemical and clinical progression. As well, blood-based cell-free DNA can predict biochemical recurrence. And in castration-resistant disease, these markers can be prognostic and predictive. MicroRNAs can predict outcome of docetaxel chemotherapy. Cell-free DNA can predict resistance to some of these novel agents. Circulating tumor cells can prognosticate disease progression and predict response to enzalutamide and abiraterone. The Prostate score may be able to prognosticate metastasis, and some of these imaging modalities may be able to predict disease relapse. Now, looking at some of the data in this field, I'm not sure that there are necessarily predictive markers. For example, in the circulating tumor cells, some of the studies looking at enzalutamide and abiraterone resistance had patients that were both treated with both. So it's hard to know if they're able to just predict poor outcome in general or if they're able to predict resistance to these specific agents. So looking at the future of biomarkers, my thoughts are future technology must improve on biomarker assay robustness. A lot of the time these assays can't keep up with where we would like to in the clinical practice, and how do we better implement them in clinical practice if they're based on these small numbers of patients, 100 patients at a time. How are we able to translate that to a population-based number of patients? And I think high sensitivity and diagnostic specificity is important in this. Well, with the novel agents arising in the management of castration-resistant disease, urine and blood-based biomarkers are very appealing to us because they encompass the whole cancer itself. And I think the development of microRNAs, cell-free DNAs, and CTC technologies in urine and blood samples will be important in predicting specific therapy outcome and sequencing these novel drugs. So where do I see the barriers? We haven't seen a lot of these used in clinical practice, so there's significant barriers to the implication of these biomarkers in real life. And I think we need to focus on, there's lots of reasons why they're not being used, but I think we need to focus on a couple of significant barriers. The need for careful clinical validation and the associated cost to the system. I think we need to incorporate some of these biomarkers into ongoing and future clinical trials. And this will be essential in implementing them into the clinic. When we look at clinical validation, there's several phases. A lot of these, there's the preclinical exploratory, clinical characterization and assay validation, retrospective studies, then prospective screening studies, and disease control. And I think a lot of these studies that I've presented today are really stuck at assay validation, retrospective repository studies. I think they need to move forward so that we look at the prospective studies and moving forward, and I think that's a major focus of where we need to move. And looking at the costs, I've already told you that the tissue-based studies are approximately $3,500 to $4,500 each for each patient, and that's significant to the system when we look at it on a small scale. The question is, would it be advantageous on a larger population-based scale? The PSA test is not very expensive, and it's controversial at this point. CTC assays cost about $350, and urine PCA3 is about $385. But I take note that in a breast cancer study recently, the Oncotype DX was utilized in a place in France, a city in France, and they utilized it in routine clinical practice. And what they demonstrated, there was a decrease in 73% of adjuvant chemotherapy by utilizing this, with no increase in the cost to the patient or cost to the system. So that's just one example. I don't think we're there yet, but I think it's an example that the implication of these on a population-based method, when we have the right assays in place, might actually lead to a cost reduction overall to the system. So again, I think we need to incorporate these biomarkers into ongoing and future clinical trials. And on that note, I'd like to open the floor to questions and thank Dr. Black and Dr. Wasserstad.